Well, I threatened that I'd be back, and I'm keeping that threat. And a lot of times when I have my break, I think of things I should have said or questions I want to ask you before we start the second half. And actually, there weren't any questions today, so I'm going to ask you the question that I always ask after the break. Did you hear well and completely without interruptions in the first half? Okay, good. I got yeses, and thank you. I read over some of your comments. I appreciate them. We'll go into the second half, and it won't be that long. It'll be a little bit more clinical. And remember, I made a little apology that a lot of the stuff in the first half, well, technically would be pathology, but a lot of it was cell biology and normal and abnormal physiology. But it all pertained to this big topic, which you should be aware of, which is regeneration and healing. We'll get a little bit more clinical. Let's get clinical. Okay, here we go. Let's pop up our PowerPoint again. And here it is. And I'm going to give you a couple of more things to put into your head before we show you some more pertinent clinical stuff that you'll see every day with your patients and with your surgeries. And long time ago, the interferons were discovered, even when I was a kid, okay? They are also can be considered not only as cytokines, but as growth factors. We knew they were very important. Made by lymphocytes and fibroblasts, but activates macrophages. And a lot of times, what they activate macrophages to do is to kill harmful substances like virus, for example. And it inhibits the fibrosis. Does that mean it might be possibly used to control scarring? Well, maybe, but like inflammation, which is a process that has evolved over millions of years to keep us alive and well, I would be very hesitant to mess with the normal process. Now, I know I'm not talking like a doctor, because doctors love to mess with normal processes like pain and swelling and heat and redness, and instantly they have a knee-jerk reaction to fix it. Well, what they're fixing is actually an expression of what it has taken millions or maybe billions of years to keep the organism, the species, the evolution alive. But interferons also regulate other cytokines as well. And remember, we said that this whole process would take place if the growth factor or cytokine works on the same cell that it's made, then that would be autocrine. If it works, in most cases of regeneration and healing, we're talking about paracrine processes. We're talking about this population of cells regenerating, dying, growing in, becoming more vascularized. They're basically working on cells in the neighborhood, so they don't have to diffuse very far. Of course, technically, if they entered the blood and worked on cells far away, down bloodstream, then you could probably say they have more of an endocrine function, even though the cells that make them are not generally known as endocrine glands. So there's autocrine. There's working on itself, made by the cell, working on the cell. Here's paracrine, the most common type of scenario in regeneration and healing, working on neighbors. And of course, if it goes downstream, that has an endocrine type function. Have to give a little word to transcription factors. We're using hepatic regeneration as an example. But a transcription factor, as overall a regulation like the growth factors, are substances that bind to actually the DNA sequence, and therefore controlling the differentiation and proliferation of the cell in future cell division. So remember, transcription factors are in that family too. I think we're all done with the substances. Now we're going to deal a little bit on the environment in which these substances, these cells are working. They're working in the matrix, the stuff between the cells, the extracellular matrix. Okay, we have collagen is probably being the #1 protein And even though you like to think of collagen as collagen, there's actually 18 different types. Maybe by the time this lecture is done, there'll be 19. We have the elastins, okay? Elastins are a type of tissue, are basically things that make tissue like a rubber band, elastic. Fibrillin as well. We have this whole big family of CAMs, which we mentioned a couple days ago. Not only immunoglobulins, but cadherins, integrins, selectins. Probably can think of, it's probably could be defined, the CAMs, as any protein which causes any adhesions between any types of cells, like antibodies and cells which bind other cells to either themselves or other cells. Proteoglycans as a chemical group, hyaluronic acid, basically very, very rich in cartilage, but is present also abundantly in the extracellular matrix. And there we go. We know that the extracellular matrix performs as the scaffolding of the regeneration and even in healing process. We know that the growth factors are stored within it, and it's within that environment of the growth factor storage and scaffolding in which the cells are differentiated. And this whole microenvironment is the area, the place, the venue, the milieu in which this whole process takes place that we've been talking about all day. Let's start out with some of the collagens. We're not going to go into all of them, but even though there's 18 different types, probably the first 3 or 4 are the most common seen. And I know some of you might have a hard time remembering which collagen does one, so I'm giving you this cute little thing here. Collagen 1, O-N-E, is part of bone. It's the main component of bone. So the main collagen of bone is collagen 1 because O-N-E is part of B-O-N-E. Collagen 2, this is stretching the imagination a little bit, is part of cartilage, okay? So the main component of cartilage within that hyaluronic acid environment is cartilage or collagen 2. Collagen 3 is part of reticular fibers or reticulate fibers, things that are very, very delicate, like bone marrow, like liver, okay? And the easiest one to remember is collagen 4 is on the floor. So most of the basement membranes in your body are composed of collagen number 4. Now we're going to be giving you a quick little list of, the other types of collagen. And I'm not going to go into all the diseases now. We'll deal with some of them a little bit later in systems, but a defect in collagen 1 would be a defect in bone. And the main bone defect for newborn kids, a disease called osteogenesis imperfecta, as well as some of the variants of hyperelasticity. Think about it. If your collagen is defective, your skin's not going to be as tight as it should, and you'd have more of an elastic type of skin, generally termed the various types of Ehlers-Danlos syndromes, EHLERS-DANLOS, hyperelastic skins that are defective collagens, not only collagen 1, but collagen 3 and 5 also. Because achondrogenesis, or the achondrogenic dwarfs the cartilage, the kids that are born with defective cartilage would be basically a defect in cartilage 2, which remember is the collagen of cartilage. The classical Ehlers-Danlos disease is 5. We have a collagen 9 called Stickler syndrome. I'm going to give you a quick description of these, whether you like it or not. In Stickler syndrome, basically there's both eye and ear abnormalities. That's the way to remember it. Collagen 4, you remember, is on the floor. That's basement membrane collagen. So they forms the basement membrane of glomeruli. So you would think a person with defect in collagen 4 would have defect in glomerular basement membranes, perhaps renal failure. Another disease, collagen 6, called Bethlem, which is basically a progressive myopathy, infects the ankles and fingers and joints. Dystrophic epidermolysis bullosa, or you can think of bullous expressions on the skin, is a problem with collagen 7. Collagen 9 problems with your epiphyses. Okay, another type of epidermolysis bullosa, a bullous type of skin disease with collagen 17. And last but not least, I think you should probably just be familiar with these terms and know that they represent forms of collagen disorders. Now remember, there's something called a collagen disease. A lot of the systemic autoimmune diseases, like lupus and rheumatoid, they were called collagen diseases. Okay, but they're not really collagen diseases, they're autoimmune diseases. But these are the genetic collagen disorders, and because most of them are basically autosomal recessive, so in many cases they appear early in life and follow the classical autosomal recessive pedigree. In the Knobloch syndrome, we have a problem with the retina as well. So there you are. Just kind of take a look at those words and remember these are abnormal, genetically imperfect, abnormal types of collagen. Just reviewing this again because we're coming near to the fun part, the clinical part. Regeneration, growth of cells to replace lost tissues, ways to make damaged areas normal again. Healing, a reparative process. Overlapping with regeneration is a reparative process response to a wound, inflammation, or necrosis. So if we remember that we talked about the inflammatory process as being a saga or a cascade or a sequence of events with one thing following another, you could probably throw in the healing process as part of that sequence. So remember, a couple days ago we ended with inflammation, and we said that, well, we're at the end of inflammation now. You could either have a scar, you could either have complete regeneration, or go into chronic inflammation. Well, the healing part follows the inflammatory part. And the main processes after that, by virtue of all of these growth factors we talked about, would be proliferation and migration of connective tissue cells to replace it. The most important of which is the endothelial cell for angiogenesis or granulation or neovascularization. And that's why granulation is also called granulation inflammation, okay? Granulation tissue often is thought of as going hand in hand as the neovascularization following the inflammatory process. The third major phase, now also overlapping with the angiogenesis phase, just like the angiogenesis phase can overlap with the acute inflammatory phase, is your collagen. Collagen coming in, collagen being straightened or remodeled. Wound contraction is basically thought of as a scar or fibrotic process that has become stronger. Perhaps you heard the term, what doesn't kill you makes you stronger. Well, you might apply that, to the fibrosis process as well, because generally fibrotic tissue is tougher than other tissue. Perhaps when you were a kid, you didn't like to eat steak because there was the grizzle, or the scar, okay, because it tasted tougher than the meat you were chewing through. Now, if you want to keep this whole thing very, very simple, and I love to oversimplify things, let's just say that this whole healing process follows the inflammatory process. So if the acute inflammatory process, basically you have, from a morphologic or histopathologic point of view, neutrophils. After a few days of that, let's say 3, 4, 5 days, you now have the endothelial cells forming the neovascularization or angiogenesis. After about a week of that, in general, if everything goes okay, give or take, you now have the fibroblastic process, which will be prominent if the tissue that was damaged severely. So the angiogenesis is from endothelial precursor cells under the influence of all the growth factors. And we said VEGF and platelet-derived growth factors were the two biggies, but just about all the other growth factors have an effect on this healing part of angiogenesis. It's also regulated by the ECM proteins, many of which are growth factors. Another name for it is granulation, granulation tissue, organizing inflammation. I said granulating inflammation, but organizing inflammation is a term that's very, very often used by surgeons and pathologists and in the medical literature as well. It's too bad that they all have so many names, but basically we're talking about ingrowth of blood vessels. So what is this? Well, if I showed you this in lab, which we're going to see in many cases this year, you might not know exactly what it is, but you know that these big red linear and round channels are probably blood vessels. So this is tissue in which you are seeing an increased abundance of blood vessels. It could also be something that is perhaps damaged and has a vascular dilatation, but this is what organization or neovascularization would look like following a wound or inflammation. And then you can say, well, what's this green stuff over here? Well, you might still see some blood vessels, but the prominent feature here are these blue areas. And collagen made by fibroblasts stains blue on this stain. This is basically a stain to show collagen and secondarily fibroblasts. So we all saw many examples of what acute inflammation looks like. So here's organization, and here's fibrosis. And if you think of them as three separate processes, you're wrong, because they overlap with each other tremendously. So if you want to think of it in terms of time, let's just say the first few days, maybe a week at most, you basically have your acute inflammatory process. But even in the middle of the acute inflammatory process, you're probably going to start proliferation of your blood vessels, okay? Granulation tissue. And even in the middle of your proliferation process with endothelial cells under the influence of all these growth factors, now you're going to have the beginning of fibrosis, or at least fibroblast deposition as well. Ultimately, after a couple of weeks, now we're up to 16 days here, ideally, we have a scar. And there's a lot of factors which could interfere with this ideal process, which I think I'm going to show you. I think I'm going to skip and I want to show you it this way. See that? Up to about 3 days, we have most of your inflammatory changes. But look, the granulation starts even sometimes before 1 day. Now, before the granulation is over, sort of in the middle of it, the collagen accumulation in fibroblasts. So neutrophils, endothelial cells, fibroblasts, if you want to keep things simple. And of course, the scarring, of course, with wound contraction can last, many days. In fact, the scar itself could last forever, of course, and you know that as well. So something I normally wouldn't teach, but I'm going to show you it because it appears frequently in exams, is this concept of first intention healing and second intention healing. They usually make a big deal of it, but it's very simple. In first intention healing, like a clean surgical incision, your edges are all lined up. You made a nice sharp cut. The edges are put back together, and you would imagine that would not only heal faster than if it wasn't a more traumatic type of tissue necrosis, but it would not produce hardly any scarring. And of course, you might say the best surgeons are the ones that leave the smallest or zero scars. That's the way a lot of surgeons think anyway. In second intention healing, the edges are not lined up. It's more traumatic. It might not be a clean surgical incision. It could be a dog bite or a piece of glass or a piece of asphalt, going through your leg. And therefore, there is more fibrosis going on because you have more of a destruction of the extracellular matrix. And here's a clean surgical incision, and you have very little fibrosis. Here you have second intention, in which you have a larger number of granulation and fibrosis, and now you have a nice scar. What is this? This is something that you might see when you're making rounds after you do surgery. You might come in the patient's room in a day or so, and you're going to look at this wound here. Maybe you've debrided it, and you're going to say, oh, well, look, it's yellow. It must be pus. It must be infected. No, that's not true. To the untrained eye, when you see something like that or that, don't think of it as being infected. Think of it as being an ingrowth of blood vessels. And microscopically, yeah, you still have a lot of inflammatory cells around, but look, there's a blood vessel, there's one, there's one, there's one, there's one, there's one, there's one. So this is normal, healthy granulation tissue. And okay, I think we mentioned this, but the deposition of collagen fibrosis is what caused the scarring. We said it would probably not be, within the first week of the injury, but it could it could start perhaps in the first week, but could basically persist not only forever, but as time goes on, longer period of time than a week, it can become stronger or it's fortified. Just like fibrin. We talked about fibrin as being the end stage of coagulation. Fibrin can be secondarily strengthened by processes, the reverse of fibrinolysis, okay? So can collagen as well. Scars can normally contract. And fibroses of certain areas not only contract, but they could interfere even with the function of the tissue or the organ. What are the things that retard the healing triumvirate, which we just discussed? Well, whether you're talking about local retarding factors or whether you're talking about systemic diseases, the number one thing is whatever retards blood supply, whether it's local or whether it's systemic, delays and retards the healing process. Well, one of the things would be if the retarding factor is denervated, okay? We all know that blood supply has a great effect on making tissue healthy and healed, but so does innervation as well. And many diabetics will be losing toes, not simply because of the lack of blood supply, but it could also be because of lack of denervation or the neuropathy. If there is a persistence of the infection, or if there are foreign bodies, perhaps a wound has not been debrided properly, perhaps there's small pieces of glass or wood or plant material that's been in there, or bacteria, that can also decrease your healing as well. What if there's a collection of blood and it's sterile, but the hematoma creates a pressure effect on the blood supply? Well, that's another reason for a local retarding factor as well. Mechanical stress, maybe a prosthesis or other physical force is pressing on that area. Mechanical stress probably could be thought of as being the same process as a hematoma. Physical pressure decreasing the blood supply. And finally, necrotic tissue. Why? Because we all know that necrotic tissue is fuel for the acute inflammatory process. So I hope that all of these things are logical to you. And I hope the next thing I show you is something that you probably would think is logical as well. What would be some of the systemic factors? Well, age, older people don't always have as much blood supply, atherosclerosis. Perhaps they have enough blood supply, but they don't have enough blood, okay? People with malignancies do not heal even normal non-malignant areas as quickly as people without malignancies. People with malnutrition, obese people, people with other infections, and of course, major organ failure. I don't care if it's lung, I don't care if it's heart, I don't care if it's kidney, okay? Major organ failure is also a factor. And I'm not going to go into the pathophysiologic mechanisms of each, because they can be very complex and things which even I don't understand. But remember, old people, anemic people, people with tumors and infections, fat people, people that are malnourished. We could probably think of obesity as a type of malnutrition. People with organ failure. In other words, really sick people don't heal even normal tissues as well as people without these conditions. I'm done. I told you it would be a relatively short day. It's only an hour and a half. I'm going to take a